Now we are going to examine the motor system. For examining the motor system, we should fulfill the following items. First, posture and involuntary movements. Then, muscle status, muscle tone, muscle power. Then, coordination, reflexes, and gait. So let's start with the first item, which is posture. How to examine posture? What's posture first? Posture is an abnormal position taken by the patient due to his illness, such as kyphosis, scoliosis, any skeletal deformity in the patient, any wrist drop or foot drop, hemiplegic posture. So we will see if there is anything like that. I cannot see any posture taken by the patient here due to his illness. افرد ايدك، خد وش ايدك عليك. There is no wrist drop. تمام. خد ارفع وش رجلك لفوق. There is no foot drop. تمام. There is no skeletal deformities. So now here the patient is normal. He has no any postural abnormality. The second item is to examine if there is any involuntary movement or not. First, what are the involuntary movements that we look for? First, if there is tremors, chorea, athetosis, fasciculations, tics, myoclonic jerks, we look for these. Let's start with the first one, tremors. To look for tremors, we should know that the tremors are maybe one of three types, either resting tremors, postural tremors, or kinetic tremors. The rest tremors, we will look at the patient while he is sitting, resting like that, and we see if there is any rhythmic involuntary movements like that. It will be resting tremors, such as in Parkinsonian patients. The postural tremors, we should ask the patient to extend his hands, افرد ايديك, and we look for any tremors in the hand. There is no tremors here. These are present in most types of tremors, and we should ask him to extend the hands. خلي ايدك كده واثبت, and we ask him to do like that, and if we see a flapping tremors, this is called astrexis, and it's present in organ failure, such as patients with hepatic failure or patients with respiratory failure. They may show some astrexis. So resting tremors, postural tremors is the second type. تمام. The third type is kinetic tremors. We should ask the patient to do the finger nose test and see if there is any tremors at the end of the movement or not. This is called kinetic tremors, and it is present in cerebellar lesions. لو سمحت ايدك الشمال افردها كده. هات صبعك على طرف مناخيرك كذا مرة، افرد وهاته على طرف مناخيرك. تمام. مش مهم السرعة، المهم انك انت تبقى جايب الطرف على الطرف. تمام. Now we can see no kinetic tremors. This is the first item, tremors. Chorea is the second one. How to see if the patient has chorea or not? First, what is chorea? Chorea is semi-purposeful, jerky involuntary movements that is irregular in place and time. That's to say, the patient may have some jerky movements like that in one limb, then it occurs in the other side, or in a third side. It is jerky, irregular in place and in time, sometimes normal and sometimes occur. So to see if there is chorea or not, we should ask the patient to stand still or ما تتحركش خالص كده. افرد ايديك كده. So he has no involuntary movements, تمام. No choreic movements, and they call it semi-purposeful because some patients, when they have choreic movements, they try to make another movement to let it be seem normal. For example, if I'm standing in front of you having such movements like that, I will do any other movement to make it disappear in front of you. So the third one is athetosis. Athetosis is like chorea, but it's slow. It is slow and twisting movement along the axis of the limb. So if the patient has slow twisting movements like that, it's chorea. It's athetosis. Usually, chorea occurs due to lesions in the caudate nucleus in the brain, in the basal ganglia. Then myoclonus. Myoclonus is a sudden jerky movement that occurs very brief, and the patients, you will see a sudden jerky movement like that. This is called myoclonus. Sometimes are epileptic, and some other causes may lead to myoclonus. Some metabolic causes such as renal failure may lead to athetosis, to myoclonus. Then fasciculations. We see fasciculations mostly with importance in anterior horn cell diseases such as amyotrophic lateral sclerosis, poliomyelitis. Any disease affecting the anterior horn cell may lead to fasciculations. How to examine for fasciculations? We should inspect each part, each limb, upper limbs and lower limbs, the muscles. First, if there is involuntary wriggling movements that occurs under the skin, we should look for how to augment these fasciculations to be seen by one of three maneuvers. The first is resting after exercise. خد ايدك عليك كده، شد جامد، ارخي بقى, and we ask the patient to rest. The second thing is to tap on the muscles with the hammer or with the hand and see if there is any fasciculation or not. The third one is to do hyperventilation, because hyperventilation leads to wash out of carbon dioxide, which is part of the carbonic acid. That's to say, we lead to losing the acid and making the field alkaline, which affects calcium and causes some hypocalcemia that lead to increase in the fasciculations. This is how to see if there is involuntary movements or not. After posture and involuntary movement, the third item is examining the muscle status. To examine the muscle status, we look for the muscle bulk, and we compare both sides. Here, the muscle bulk is normal for his age. It differs when examining a patient that's in the age of 80 or 90 years to see the muscle bulk. We compare it for the normal for his age. Here he has a normal muscle bulk. Sometimes if we are confused, we can fix a bony point here and go 3 or 4 centimeters below, and by the meter, and we could measure the circumference here and the circumference on the other side and compare both sides by number from a bony prominence. The muscle status may be one of three: either normal muscle status, such as in this patient, or atrophy or hypertrophy. Atrophy occurs usually with lower motor neuron lesions or this is more common with anterior horn cell diseases and lower motor neuron causes. And also it occurs with disuse atrophy with upper motor neuron lesions. But it occurs more late. The atrophy with lower motor neuron lesions occurs early, while atrophy with upper motor neuron lesion occur due to disuse atrophy and is late in time. Hypertrophy is usually due to muscle exercise or anabolic steroids. Pseudo-hypertrophy, when we see a patient with hypertrophy but accompanied by muscle weakness. This is how to examine the muscle status. The next item is to examine muscle tone. To examine the muscle tone, we should ask the patient to be passive and do not move his hands with us. That's to say, examining the muscle tone is examining the movement around a joint without any resistance. We usually examine the muscle tone around the wrist, around the elbow, and around the knee. We should ask the patient to be relaxed. ارخي نفسك خالص. And I do the movement around the wrist and compare with the other side. And around the elbow. ممكن تنام. And around the knee. ارخي نفسك خالص. And I should ask the patient to relax and flex and extend the limbs. What are the findings that we may have here? In patients with upper motor neuron lesion, they have an increased muscle tone in the flexors of the upper limb and extensors of the lower limb. That's why they walk like that. The patient with hemiplegia, he walks like this, and he has an extended limb here and a flexed limb here. How will this be seen in the examination of the muscle tone? The tone with the biceps is higher than the tone with the triceps. So it's more difficult to extend the hand because of the tone of the biceps. But it's easier to flex the hand due to high tone in the biceps and low tone in the triceps. So I will find more resistance during passive movement in extending the hand than with flexing. So when I see the tone is increased, I may have one of two things, either rigidity or spasticity. Spasticity occurs with pyramidal lesions, while rigidity occurs with extrapyramidal lesions. The difference is that with rigidity, I will have the tone, increased tone during extending and during flexing. While in spasticity, I will have the tone increased more during extending the arm against his flexors than during flexing the arm, because the flexors will help in more flexion. So patients with spasticity will have more tone in the flexors than extensors, while patients with rigidity have increased tone, equal increased tone in the flexors and extensors. That's behind what do we feel in this. So in patients with rigidity, I will have increased tone like that and that, while in spasticity, I'll have it here more than this way. And in rigidity, I will have increased tone both during trying to flex and extend in rigidity, while in spasticity, the tone is increased in the extensors more than flexors. So I will have more resistance in with the extensors. Then after 90 degrees, the tone is with the flexors, so it will have some release. So I will have an increased tone first in trying to act against these extensors till here. Then after 90 degrees, the tone will be more with the flexors, so there will be a release. This is called clasp knife, like the closure of a knife. So when examining the tone, I may have one of three things: either normal tone, hypotonia, or hypertonia. Normal tone is like this one. And I should compare both sides. Hypotonia, when I see the patient floppy or having a very low tone. And this occurs in certain situations. First, with lower motor neuron lesions. Second, with shock stage of upper motor neuron lesions. And in patients with chorea and cerebellar disease. These situations we may find hypotonia. Normal tone is present in every normal situations. Hypertonia may be one of two things: either spastic, this occurs with pyramidal lesions, or rigid with extrapyramidal lesions. The next item is to examine the muscle power. To examine the muscle power, we should ask the patient a certain action to do, and we resist it. For example, to examine the biceps reflex, the biceps muscle, I should ask him to flex the arm and try to resist this action. شد ايدك عليك كده جامد، انا ما تخلينيش اشدها. This is how to examine the biceps. The triceps، افرد ايدك على الاخر، خش بايدك جامد. I am asking him to extend the arm, and I'll try to reverse this, and he should resist me. This is the motor power of the triceps. In each limb, I examine distal and proximal. اقفل كده على صبعي جامد. This is the hand grip. ما تخلينيش اطلع صبعي. This is the hand grip. اتني ايدك كده. اتني بس. wrist flexors. افرد لورا. wrist extensors. خد ايدك عليك. elbow flexors, biceps and the elbow flexors. افرد ايدك على الاخر. elbow extensors. Then the shoulder flexors. ارفع ايدك لقدام كده. This is the shoulder flexors. And shoulder extensors. هات ايدك لورا. انزل كده. زق لتحت. طيب abductors. The abductors are 3 degrees. The first 18 degrees are with the supraspinatus muscle. زق لبره. طيب from 18 up to 90 degrees is with the deltoid. افرد ايدك لبره. زقني. زق. This is the deltoid. And above 90 degrees ارفع ايدك خالص. لا. I should let him اقعد. طيب احسن. افرد ايدك كده. لا كده اهو. ارفع. And abduction above 90 degrees is more with the trapezius muscle. تمام. بعد كده حط ايديك الاثنين هنا واضغط جامد. I should ask the patient to put his hands like that and press, and I should examine the muscle power of the pectoralis and the latissimus dorsi. بعد كده افرد ايديك والمفروض يزق على الحيطة. اقف وزق هنا. And I see if there is winging of the scapula or not. تمام اتفضل. The winging of the scapula occurs with serratus anterior muscle weakness. تمام. Then I'll go to the lower limbs and examine first the foot. خد وش رجلك عليك، زق جامد، زق لتحت جامد، dorsiflexors and plantar flexors, then around the knee, knee flexors. اتني رجلك، خد رجلك عليك جامد، ما تلزقش رجلك في السرير كده، سيب رجلك. If I do like this, he may be acting with the flexors of the knee and also the flexors of the hip. So I should take the flexors of the hip out of the action. Now this is the flexors of the knee only. اتني رجلك لتحت عليك جامد. These are the flexors of the knee. Extensors of the knee. افرد رجلك. I'll ask him to extend his knee and I will try to flex it. افرد رجلك وخشبها جامد. These are the extensors of the knee. Then the hip, flexors and extensors. I'll ask him first to flex the hip. ارفع رجلك لفوق. And I'll try to resist him. These are the flexors of the knee. Of the hip. Extensors of the hip. نزل رجلك لتحت. الزقها في السرير جامد. جامد. These are the extensors of the hip. Lastly, the abdominal flexors. حط ايديك كده وقوم بوسطك. Then we should grade the muscle power according to the grade 5, grade 4, 3, 2, 1, 0. Grade 5 is the normal muscle power. The patient can resist with a normal muscle power. Grade 4 can resist but with less power, so there is some weakness. Grade 3 cannot move against resistance, but can move only against gravity. This is grade 3. Grade 2, when you ask the patient to move against gravity, he cannot. But if you let his arm is against gravity, he can move it. So grade 2 is with elimination of gravity. Grade 3, movement only against gravity. So grade 5 is normal. Grade 4 can move against resistance, but less than the normal. Grade 3 can move only against gravity. Grade 2 with elimination of gravity. Grade 1 just flickers. When you ask the patient to move against gravity, he cannot. And with elimination of gravity, he cannot. So he is not grade 2. Only flickers in the muscles occur. This is grade 1. Grade 0 can not do any movement. This is the grading of the muscle power. So we examine the muscle status, muscle tone, and muscle power. The next item is the reflexes. Then the following item is to examine the reflexes. The reflexes are either the deep reflexes, superficial reflexes, visceral reflexes, or the pathological reflexes. First, the deep reflexes. We have the biceps reflex, brachioradialis reflex, triceps reflex, knee reflex, and ankle reflex. The levels of these reflexes are S12, L34, C56, C56, C67. That's to say 1, 2, 3, 4, 5, 6, 5, 6, 6, 7. The biceps 5, 6, mainly 5. The brachioradialis 5, 6, mainly 6. The triceps 6, 7, mainly 7. That's to say 1, 2, 3, 4, 5, 6, 7. How to do these reflexes? First, we should do it in the right position. For the ankle reflex, I will ask the patient to flex his knee on the other one, like this. To do the ankle reflex, I should expose the muscle first. I should expose the muscle. First, I will tap on the tendon Achilles after stretching it. This is the first thing, to stretch the tendon. ارخي نفسك خالص. سيب نفسك، ما ترفعش معاه حاجة. سيب. Stretch it first. Then tap on the tendon and see. This is the ankle reflex. The knee reflex, we should flex the knee in an obtuse angle like that. سيب نفسك خالص. ارخي نفسك. And locate and palpate the ligament, the patellar ligament, and tap. We should expose, sometimes we should expose the muscle to see, or we can see the movement of the knee. The biceps reflex, I should position, take this position. The patient puts his hand under the inguinal ligament like that, resting on the bed. I should localize the tendon of the biceps, and I should tap on above it, above my finger like that. The brachioradialis, I should put the limb in the midway between supination and pronation. This is pronation and this is supination, and we should put it midway like that. We should localize the end of the radius, styloid process of the radius, and go 3 fingers above and tap. We should expose the muscle also and tap 3 fingers above the styloid process of the radius and see if there is any movement around the elbow or movement in this brachioradialis muscle. The triceps reflex, we should put the hand flexed 90 degrees like that, and remove the other hand not to be in front of this hand and resist the reflex. The hand is 90 degrees. Here we can feel the bone. We go behind the bone here, the end of the humerus. We go like that and tap here and see the extension of the hand. Then after making the deep reflexes, we should grade the reflex. What are the grading of the deep reflexes? It's either grade 0, 0 plus, 1 plus, 2 plus, 3 plus, or 4 plus. So what's grade 0 and 0 plus? When I have a patient, when I do the reflex and it is absent, I would ask for reinforcement. The reinforcement is made by one of 2 maneuvers, either clenching the teeth or clenching both arms with each other. So, when I'm doing a reinforcement in the lower limb reflexes, I can ask the patient to either clench the teeth or clench both arms with each other. When I'm doing the reflex in the upper limb and it is absent, I only ask the patient to clench the teeth. If the absent reflex occurred, it's called 0 plus. If after reinforcement it did not appear, it is grade 0. This is the first thing, 0 or 0 plus. What if the reflex, when doing it from the first time, it appeared just elicited? It's called 1+. If it occurred exaggerated, it's called 3+. Between 3+ exaggerated and 1+ just elicited, the degree in between, we call it brisky, and it's 2+. So 1+ is just elicited, 2+ is brisky, 3+ is exaggerated. 4+ is exaggerated with clonus. What's clonus? And where could we find or elicit the clonus? It may be found in the ankle or the patellar reflexes. How to elicit the clonus? In the ankle, we flex the knee 90 degrees and sudden sustained dorsiflexion of the foot is done. And we see if the patient has some movements like that, it's called clonus. So ask the patient to relax, ارخي نفسك خالص, and we do sudden sustained dorsiflexion of the foot like that. Okay? And if we see clonic movements like that, repetitive movements, it's called positive clonus, and it is grade 4 reflex. How to do the patellar clonus? The idea is to sudden and sustainedly extend the tendon of the quadriceps with the patella in front and see if we have a clonic movement like that or not. So we will have a punch of the skin backward like that, and try to catch the end of the quadriceps muscle and do sudden sustained extension of this muscle. If the patient has movement like that, it's called patellar clonus positive, and it is 4+. So these are the deep reflexes. Then the superficial reflexes. The main two superficial reflexes are the abdominal reflex and the plantar reflex. First, the plantar reflex, we have a blunt object like the end of this hammer, and we try to move it at the lateral aspect of the foot and see the movement of the big toe. In this patient, he had flexed his big toe, and this is the normal response. When doing this reflex, the patient may have flexion, extension with fanning, or no movement, or equivocal movements. So we have one of 5 findings to result with. Either flexor plantar, and this is normal. Extensor plantar occurs with pyramidal lesions. Extensor with fanning, this occurs with pyramidal and extrapyramidal lesions. When you do the reflex, you have no response at all, and it's called unelicited plantar reflex, and it has no significance. And the 5th is to, when doing the reflex, you have equivocal movements, sometimes flexion and extension. You recur it again with equivocal movements. So flexion, normal, extension, pyramidal, extension with fanning is called Babinski positive and occurs with pyramidal and extrapyramidal lesions. Equivocal and unelicited are with no significance, with no clinical significance. This is the plantar reflex. Then the other superficial reflex is the abdominal reflex. اكشف بطنك. The first thing to ask the patient is to flex the knee mild flexion. اتني رجلك كده والتانية زيها. And we should scratch with, you see here the movement, this is the present abdominal reflex, this is the upper abdomen, and this is the lower. This is the upper and this is the lower. The abdominal reflex is absent with pyramidal lesions, and in some obese patients it's difficult to see it like this patient. So it's absent in pyramidal lesions and in some obese patients, but it's not significant in those obese patients. تمام. Then we have the visceral reflexes, and we should ask the patient about urine control, stool control, and about if there is impotence or not. Then the pathological reflexes, such as Hoffman reflex. هات ايدك كده. Hoffman reflex, I should punch the middle finger and see. This is normal that these fingers did not move, but with positive Hoffman reflex, when I do a patient this reflex, he starts flexion occurs in the other hand. This is positive Hoffman reflex, and this is a pathological reflex. Finger jerk, اقفل على ايدي، امسك على ايدي مسكه بسيطه، سيب شويه سيب شويه، امسك مسكه خفيفه. And I should tap here like that. And if the patient have reflex flexion in all fingers, this is positive finger jerk. Then glabellar reflex, I should tap on this area and see if the patient blinks 4 or 5 times and starts to stop blinking, this is normal. But if he persists blinking, this is positive glabellar reflex, and it occurs in some diseases like Parkinson's disease. The Hoffman and the finger jerk indicates a lesion above dorsal 1. Then the frontal release signs, we should do like that. And if the patient, this is the grasp reflex, if the patient, when I do like this, he closes his fingers, this is called the grasp reflex. And the snout reflex, I do like this. If the patient starts to move his lips like this, it's called the snout reflex. And these are frontal release signs and indicate pathological lesions in the frontal lobe. And usually these reflexes are present in infants, and they disappear after the age of 6 months. They should not persist until adulthood. Then we will examine the coordination. The coordination should be examined in the upper limbs and the lower limbs. In the upper limbs, the patient is asked to do a finger nose test, finger to finger, rapid alternating movements, rebound test. First, finger to nose finger. عايزك تعمل صبعك تجيبه من الجنب كده ويلمس طرف المناخير. افرده، هاته تاني. تمام. This is a normal finger to nose test, but when abnormal, the patient starts to have intention tremors at the end of this, and he may have past pointing or pre-pointing. This is called dysmetria, or he cannot touch the intended point. He goes after or before, past pointing or pre-pointing. Then ask him to do the finger to finger. هات ايديك الاتنين على بعض كده. افرد وهاتهم تاني. لا، صبع واحد. تمام. If a patient has a cerebellar lesions, he cannot get these fingers to each others. تمام. عايزك تعمل كده اسرع. طيب اعمل كده. لا بص، ثبت ايدك هنا كده واعمل بالايد التانية. تمام. These are rapid alternating movements. If the patient cannot do this movement, it is called dysdiadochokinesia. Then the rebound. افرد ايدك كده. I should. طب ممكن تقعد؟ خلاص. طيب افرد ايدك كده. I should ask the patient to raise his arms up and I will resist him and I'll suddenly release this movement and see if there is a rebound phenomena on one side. This tells that there is abnormal cerebellar function on that side. If there is overshooting movement in one side, this is called the rebound phenomenon. تفضل نام. This is how to examine coordination in the upper limbs. To examine coordination in the lower limb, we have the finger heel, knee, shin test. We get the heel on the knee and then on the shin of the tibia, and it is called heel, knee, shin test. How to be done? First, ask the patient to raise his leg. ارفع رجلك لفوق كده. نزل كعبك ده على ركبتك هنا وامشي على العظمة لغاية تحت. If there is zigzag movement, ارفع. نزل على ركبتك. If there is some confusion and he cannot reach the knee, reaches pre or post pointing, or انزل كده لتحت, or he has zigzag movement on the leg, it's called abnormal heel, knee, shin test. Then let the patient stand and ask him to walk a tandem gait on a line like that. And if he sways to one side, this indicates a lesion on the same side of the cerebellar. For example, a right cerebellar lesion leads to swaying to the right side. When tandem gait like that, he sways to the right side. This occurs with right cerebellar lesion. If a patient has bilateral cerebellar affection, he cannot walk on a narrow base. He should walk on a wide base. This indicates bilateral cerebellar lesion. Then we will make a Romberg's test. We will ask the patient to stand first with his legs near each other and with eyes open, then ask him to close his eyes like that. If he starts to sway after closing the eyes, so he has a deep sensation problem. But if he starts to sway from the beginning when he is opening his eyes, this is a cerebellar problem. And this is called, when closing the eyes, if the patient sways, it is called positive Romberg's test, and it indicates abnormal deep sensation in the lower limbs. Then we should examine the gait of the patient, as it can indicate what's the problem. We will ask the patient to walk and see if it is a normal gait or indicates any abnormality. ممكن كده عايزك تقوم تمشي وارجع تاني. امشي عادي. ارجع. تمام، اتفضل. اتفضل. Here we can see no abnormality. In some diseases, we can see a particular gait. For example, in hemiplegia, we can see the gait of the patient. If the patient has hemiplegia on the right side, he will walk normally by the left side. He will have flexion first, then he puts his leg like this. But on this hemiplegic side, you will see that his arm is flexed and somewhat pronated, and his right lower limb is extended, so he cannot do it like that. He will have circumduction gait like this. And this is called circumduction gait. It is due to spasticity and increased tone in the extensors of the lower limb and extensors of the upper limb. The patient cannot flex his knee, so the extended knee leads him to have circumduction to get it in front like this, and this is called circumduction gait and occurs with pyramidal lesion. If we see a patient with muscle weakness, he will have proximal muscle weakness more than distal. So when we are moving the leg like that, his proximal muscles cannot lift the hip. So this patient may walk like this, trying to weight his to move his hip with the trunk muscles like that, to elevate the hip with the trunk muscles. And this occurs with myopathy, and it's called waddling gait. So if you see a patient walking like that, it's called waddling gait, and it occurs due to myopathy and proximal muscle weakness. And if you see a patient limping like that, this is called antalgic gait. It occurs due to pain in one of these limbs, so the patient tries to not to have a long time bearing his weight on this limb. So he walks by this one and take a short time on this and it's called a limping gait. Patients with foot drop, they walk like this. If I have a foot drop here, I walk normal with this one, but I should elevate the other one. This is called high steppage gait and occurs in foot drop. So foot drop in the left side, I will walk normal with this one, but high steppage with the other one. If I have bilateral foot drop, I will walk like that. This is called bilateral high steppage gait. The patients with abnormal deep sensation usually walk, they don't feel the ground and they don't have good deep sensation to feel the ground. So they try to feel the ground more, and this gait is called stamping gait. They are trying to feel the ground more like that. So walking like this is called stamping gait. Spastic gait, in some patients having hemiplegia bilaterally, they may have spastic gait like this due to extension, and sometimes they have scissoring like this. This is called spastic gait. Some Parkinsonian patients have rigidity in both upper and lower limbs and flexed attitude, and because of the rigidity, they don't have a wide step, so they have short steps and shuffling gait, and this occurs with Parkinson disease. Some patients with cerebellar diseases walk on, with bilateral cerebellar, they walk on wide base, and this is called wide base gait due to cerebellar abnormality. And now we will examine the sensory system. Sensory system examination includes superficial sensation, deep sensation, and cortical sensation. For superficial sensation, we will examine pain, touch, and temperature. The pain sensation we will be examined by a disposable pin, and we will start by asking the patient if he feels in a normal area that he didn't complain of. حاسس الشكة دي؟ حاسسها؟ تمام؟ دي كده ودي سليمة صح؟ حاسسها كويس. هشكك في رجلك وتقول لي حاسسها زيها ولا أقل؟ طيب دي زي دي؟ زي بعض؟ أجمد شوية. طيب حاسس دي؟ كل ده زي بعضه؟ طيب اكشف بطنك. طيب كل ده حاسه؟ حاسس هنا؟ طيب هنا حاسس زي هنا؟
لا اكتر.
طيب والاحساس كده كله محسوس كويس؟ حاسس كده؟ طيب we will compare both sides with each other. We will have some patterns. If we have some patterns of decreased sensation, for example, if we have glove stocking and glove hypothesia, this occurs with peripheral neuropathy. If we have certain root affection, for example, L4, L5, C6, C7, this is a radicular affection. If we have hypothesia during all over the lower part of the body and starts sensation from this area and upwards, so this is a sensory level which occurs with spinal cord lesion. If we have multiple areas of decreased sensation, this occurs with polyneuritis multiplex. So peripheral neuropathy manifests by glove and stocking hypothesia, radicular sensation with root affection, sensory level with spinal cord affection. These are the patterns we are looking for during sensory examination with the pin. And we will do this the same using a cotton. حاسس دي كده؟ طيب حاسس دي زيها؟ طيب دي زي دي؟ طيب الإحساس كده كله حاسه كويس؟ كده؟ By the cotton we will examine the touch sensation. Usually pain and touch are carried by the spinothalamic sensation, by the spinothalamic tract, and they are affected with each other except in one case only, where we have dissociated sensory loss. And this occurs with central lesions of the spinal cord, because the fibers that affect pain are intact while the fibers that affect touch are affected. So when you find that the patient in a certain area, for example, from here to here, doesn't feel the touch but feels the pain, this indicates there is a syrinx or central spinal cord lesion between dorsal 10 and dorsal, for example, 5. And this occurs with syringomyelia. Lastly, we will examine the deep sensation. We examine the superficial sensation, then the deep sensation. To examine the deep sensation, we will examine joint movement, joint position, and vibration sense in the upper limb and lower limb. So we'll start by joint movement sense in the lower limb. We will fix the joint here, the proximal joint, and we will move the interphalangeal joint. بص كده صبعك لتحت، كده لفوق، كده بيتحرك، كده ثابت. لما اقول لك كده تقول لي تحت، كده هتقول لي فوق، كده هتقول لي بيتحرك، ولما اسيبه خالص يبقى ثابت. I'll describe what I'll do to the patient. First, I'll tell him that this is downward, this is upwards, this is moving, and this is not moving. طيب كده ايه؟ وكده
كده تحت
وكده كده وكده
تحت
كده تحت
في النص
كده
تحت
وكده.
فوق.
And we will do it several times to ensure that the patient can feel it well. This is called the joint movement and joint position. Position is upward or downward, and the joint movement, that is it moving or not. So joint movement, joint position, and vibration sense. The vibration sense, we will use the tuning fork 128. We will tap on the fork and put it on a bony prominence in the forehead here. حاسس الزنة دي؟ طيب. And we put it on the medial malleus. حاسس كده زنة؟ حاسس كده؟ طيب حاسس كده؟ طيب. So if the patient feels here, so the deep sensation that is carried by the posterior column is intact. If the patient doesn't feel this at the medial malleolus, we are aiming to see if this is a peripheral neuropathy or a spinal cord lesion. If the patient doesn't feel here and the anterior superior iliac spine, he doesn't feel, and he feels it on the ribs or on the clavicle, so this is mostly a spinal cord lesion. But if he doesn't feel it here and can feel it at the anterior superior iliac spine, it's mostly a peripheral neuropathy. Then after the deep sensation, we will examine the cortical sensations. The cortical sensation is simply what the cortex has more to feel than the peripheral sensation. Usually the sensation passes from the lower limb to the spinal cord and crosses to the other side, passing first to the thalamus as a first relay, then the cortex as the last relay. The thalamus can feel, but the cortex has more complex functions. So the cortex can feel and the thalamus can feel, but the cortex has more delicate feelings that can feel where did I point exactly, so it's called tactile localization, and 2-point discrimination and stereognosis or graphesthesia. First, tactile localization. I will ask the patient where exactly I'm touching him. عايزك while closing his eyes عايزك تغمض عينك. لما هشكك في حتة شاور لي عليها بالإيد التانية. This is tactile localization. 2-point discrimination. بص I'll describe for him. دي شكة واحدة، دول شكتين. تمام؟ عايزك تغمض عينك كده. I'll do now 2-point discrimination. هتقول لي دي واحدة ولا اتنين. And I'll ask him if he feels 1 or 2 pain pricks.
اثنين. واحدة. واحدة.
When I come very near to each other, he can feel it in some areas. Except the hand, he can feel it 1 pin prick. For example, when I come very near like that, he feels it 1 only. But here in the hand, افرد ايدك كده. اثنين. He can feel 2 pin pricks because the hand has very large areas in the cortical representation. طيب كده 2. So this indicates that he has intact cortical sensations. This is tactile localization and 2-point discrimination. The last one is stereognosis. I'll ask the patient to know something, an object from its texture. For example, I'll put him this in his hand and ask him what's this. خليك مغمض عينك كده. اللي انت ماسكه في ايدك ده ايه؟ اقفل عليها كده.
آلة كنت شغال بيها حضرتك، اللي هي بتاعت اللي هي فيها زنة.
الشكر ان انا لسه كنا ماسكينها. تمام. I'll put him another thing.
صابون. ده جهاز.
جهاز ايه؟
جهاز سكر.
مفتاح.
مفتاح عربية.
مفتاح عربية. تمام. So he can know the object from its texture, and this is called stereognosis, and this indicates intact cortical functions. So the cortical functions are tactile localization, 2-point discrimination, and stereognosis. At the end of the sensory examination, we should conclude what's the problem. We have either peripheral neuropathy, and this may present by glove and stocking hypothesia. We may have an affection of a single nerve, and the distribution of affection, for example, in the ulnar nerve will be in the distribution of the ulnar part. We may have a root radicular affection, and this usually affects a single radical. So now we should know the sensory distribution of these radicals. In the lower limb, this is the upper thigh is L1, the middle is L2, and the lower third is L3. Then L4 is in the medial part of the leg. L5 is on the lateral and dorsum of the foot. S1 is on the plantar part of the foot and the back of the leg. L2 is on the back of the thigh, and L3, 4, 5 are around the saddle-shaped area. Dorsal 10 is at the umbilicus, dorsal 7 is at the lower costal margin, so D7 is here, D8, 9 are here, D10 is here, L1 is here, so dorsal 11 and 12 are above the inguinal ligament, below is L1. Above the costal margin, D7, at the nipple line, D4, so D5 and 6 are in between here. D4 is at the nipple line. The sensory distribution here is D3 and D2. C8 is on the medial part of the arm. Dorsal 1 is here. C8 is on the medial part of the forearm, C8. C7 is in the middle finger and an area above. C6 is the thumb and the index finger and a part of the forearm. C5 is on the lateral part of the arm. C4 is here. So dorsal 4 on the nipple line, dorsal 3, dorsal 2 is here. Then C4 is above, C3, C2, and then the trigeminal nerve. This is the distribution of the sensory area. And these are called the dermatomes. We use them to know if this affects a radicular sensation of any radical in the upper or lower limb or not. If the sensation is lost in one limb, so this is a plexus lesion. So if I have an affection of one limb, this may be a plexopathy or brachial plexus lesion. If I have an affection of one part, the right side, upper and lower limb, the affection may be in the cervical region on one side. If I have affection of the lower part of the body, the affection may be in the spinal cord. If I have an affection in one side plus the face, the affection usually is in the internal capsule of the other side. If the affection affects only the area of C8, for example, this is a radical, so the affection is in the root of C8. If the affection is glove and stocking, this is a peripheral neuropathy. If the affection is on the area supplied by the radial nerve, this is a single nerve affection. If I have patches of different nerve affection, this is called polyneuritis multiplex. That's all.